I do want it to be interactive. I do want to like, that's why, you know, hopefully it will give everyone that's in the room, from the first years to the attendings, something, a different way to a different perspective, or something that they can take home. So please ask questions, interrupt, whatever. And so when I'd asked David what to talk about, he said Stridor. And so Stridor, I started thinking more about what else beyond Stridor. Like 45 minutes is a long time to talk about just Stridor. And Dr. Khan and I have had these conversations about all sorts of noisy breathing that we feel are very, very important for everybody to sort of really know about. So with that, if I can actually advance slides, that would be good. No, that's not it.
Yep, right there. So then once you click on this, you can just use the arrows.
No. No? Oh, okay. So we're going to kind of look at these things. The way I think of all these things, it's almost like the way I look at literature in general. I don't kind of like look at the first thing and then I'm like, oh, it always makes total sense. I usually kind of try to get a three-dimensional view of things. And so because of that, we'll kind of look at noisy breathing from different perspectives and see which one kind of fits with the way that you think. One of the ways that I like to look at everything in pediatrics, because kids are not just small adults, is across the ages, looking at sort of the difference of the things that you should think of, whether they're infants, toddlers, school age, or adolescents. The other thing is that we're not going to cover traumatic and sort of bacterial infections, because they kind of, in their own way, they're generally a little bit more obvious, or they have more that will kind of clue you into those things. So of note, we're just going to not deal with that. One of the things that is key to all of this noisy breathing, that's sort of like an overarching theme, is whenever you have something that is good. So you breathe through your nose, you breathe through your mouth, you breathe through your airways, your A and your B. And then it becomes noisy when you change something about the flow through that air, right? So one of the things that is another unifying thing with all of this sort of noisy breathing, for the most part, is that, or if it's an acute change for the most part, is snot, is a cold, is snot, is edema. And so that's another thing that, like, if you think about that, this is going to come along with these differentials that you're thinking about. So I guess my point is that you have a cold, and then you also have a lot of other reasons that can be causing noisy breathing that you should consider, but you shouldn't walk away always just saying, well, they have a cold and I'm done, because it's the combination of the cold and whatever else is going on that is actually the problem. So we'll take a step back and think about what we are actually talking about when we talk about noises. There tends to be these three divisions that people like to use. This is not a totally precise slide, and I'll give the flip side of this in a second, because there's the inspiratory sounds, which are right, like, and so when you also look at the patient, they tend to have retractions that start at the top as opposed to the bottom. So if you think about, you do it yourself, that's what they kind of look like, that's what they sound like. That is inspiratory stridor, and that's coming from up here. Going down to the bottom, they say expiratory stridor, but it's really what we tend to think of as wheezing, right? Because that's going from it's pathology that's going on down below, and it tends to be the stuff like the bronchiolitis, the mucus plugging, the airway narrowing that you're trying to push stuff out of, and that you get that expiratory wheeze. And then, of course, because nothing is truly black and white, you have the middle where you have the biphasic sounds you get. So again, looking at sort of the same thing in a different way. I like this in the sense that it does kind of remind you of the definition of wheezing, which is, and actually all of these noises, they're vibrations of turbulent flow against narrow airway walls. Again, whether that's upper airway, middle, or sort of lower airway. leading to high-pitched musical sound. And so using wheezing, again, that's lower as opposed to upper, which is stridor, like that. They too break this out into larynx. And so this goes a little more into the actual differentials as far as you're talking about what is up there. It's your upper airway, which isn't on here, but then your epiglottis, your laryngeal stuff, your vocal cords. And then on the bottom, again, all the lower respiratory things. And then sort of the middle part as far as your, like your trachea, and more like the vascular rings and the masses, which I guess more, I was thinking about this more, that I guess adults tend to have more mediastinal stuff as opposed to kids, but there are some of those things in there. And so that you do need to be aware that they could be, you know, the bottom line is not all that wheezes, not all that makes noises. It's just sort of straightforward, which is the point of this whole talk. And so since I said, you know, I always learn something making these lectures and sharing something that maybe somebody tends to know about or whatnot. I was like, relapsing polychondritis. What is that? How many people know what that is? Okay, good. It's something that doesn't happen to kids though. It's like in their 40s or 50s, you get this like relapsing, all your chondri, like in your ears and your trachea, and it sounds miserable. It kind of gets itis and inflamed and kind of melts, and it just sounds awfully horrible. But that's what that is. Uh-oh. Okay. Last picture to look at it again, sort of the same thing in a different way. And especially, you know, talking about the airway. And this one I like because it includes the upper airway. Again, we have to, when we talk about noises and we talk about air movement, it starts from the outside here. And so snoring and adenoids can be a big deal. And this gives you some of the actual pathology that tends to occur in kids and that we're going to go over more specifically. And so you're going to hear it a couple of times that hopefully they'll stick: laryngomalacia, vocal cord palsy, so the subglottic stenosis, any kind of masses in that area going down below, foreign body, tracheomalacia, like again, more tracheo, not laryngo. Vascular rings, tracheal stenosis, and then, like we said, compression by any sort of mass. Okay, so I was saying that I'm pretty low tech, which is why I've given up here. No, right click.
Yep, and then this one, the second one.
Oh,
yep.
Okay. So can I get?
I have to use that video. So if you,
that's okay.
Yeah.
So looking at what we're talking about, you know, so we want to just make sure we're on the same page. And so grunting, oh wait, that is the third one. That's what you're trying to tell me. Yes, yes. Wait, where'd the other ones go?
Right over here. You want this one?
Oh, you put the other. Okay, we'll start with that one.
Okay.
So volume.
I don't know. Yeah, I can't. I don't know if it's to work. No, it's not. The volume.
So do the people at home hear it? No. Okay. All right, so now I got to do grunting and stridor. So grunting, or not grunting, wheezing. Well, wheezing, you've all heard wheezing. As far as the stridor, you know, it's the stridor that you're worried about tends to not be the one that happens when people are upset, but when they're quiet. And so that's why it's like,
oh, that sounds like it, right?
But it's that little, so it doesn't have to be like super dramatic. I guess that's really the point. But these are these small noises, because if they're not, you know, breathing hard, the noises that they make, but they're very, very important for you to pay attention to.
Yeah. Can you guys kind of hear that?
Okay.
So let me know if that's a little too loud, but I think that's okay.
And then, yeah, just do the other one.
Yeah. Sorry, my bad. Okay.
It's the little one.
Yeah. So
We are going on a fast.
Can you hear that? It's quiet, but that's sort of the point, right? And you got to listen for it.
so you can hear that going in. Can you guys hear that? Claro, still go.
So that's the example of Stridor, to make sure we're all on the same page with that, but it's not necessarily going to be that. Their allergies, he's obviously having a lot of trouble breathing.
Do you guys hear that sound? That's classic for Stridor. No, you want to do the next one? Yeah. Okay. Wheezing or grunting? Okay, I think I already closed that one. I'm gonna do. You can hear the wheezing there.
But again, it can be very subtle, and that's the point. That, it's important to kind of listen to. That's good.
Yeah, great. Do you want the grunting one or you good? Okay, great.
Thank you, Rosie.
Yeah, of course.
All right.
Just make sure the presenter view is here with you. Okay, sounds good.
That's all right. I'll figure it out. Oh, except for then I don't see it at all. No,
yeah, but like usually we do presenter view over. Let me just try quickly.
it's just supposed to be like to keep you awake and kind of fun, but instead it's like nap time. Sorry.
So I'm just like
So if
dragging it
you,
over.
you just do just click on this.
Present,
yes,
presenter view.
and
Okay.
then drag.
Yeah,
this
that's
one
right.
over.
Okay, thanks. Perfect. So now you have.
Okay. So now we're just gonna kind of break these things down into sort of differentials and kind of some pearls on when you should actually think about these different things. So to start with, we're gonna start with the neonate. Neonates are between 0 and 28 days by definition. And I chose sort of 4-day-old, and I'll explain to you as we go why I chose 4-day-old. But what is the differential? What do you think? You have chief complaint on there, 4-day-old, noisy breathing.
Nasal congestion.
Yes, nasal congestion.
General hernia.
That would suck. Yes.
But from the least problematic to the most problematic.
tracheolaryngomalacia. Come on. Anything? Normal baby squeak. Oh, you know what? I didn't put, and that's a really good. So normal baby squeak is something that it's also known as like preemie grunt. That's what I always think of it as. Because when you guys rotate through the newborn nursery, have you ever heard this in the newborn nursery? They go around, like, especially like, they get to be like about term when they were preterm and they start going, but it's not really grunting. It's like, they go, like, it's, I should have done a video of that, but it's more like a type of thing. And that's very benign, but it does freak people out the same way that like the rest of these should freak people out. So it is very important. Like I said, Dr. Khan and I have had all sorts of conversations about noisy breathing and why it's really important to understand and kind of like decide which one you're going to jump out of your chair for and which one you're going to be like, I'm good with that. Okay, so the top two, so again, going from less problematic to more problematic. There's nasal congestion. I'm going to really go into the ones that are bolded, but nasal congestion, laryngotracheomalacia. I have in parentheses like little things that you should think about. And then craniofacial abnormality. I mean, the one that you're really thinking about for the relatively normal baby would be coinal atresia, because if you have like severe micrognathy, like again, that's pretty obvious. And you can also have vocal cord paralysis. So these are some of the things that, you know, outwardly, and they may have gone through the nursery, but, you know, they got home and grandma's like, this is not right. And they come back. So we're going to start off with the most benign, but most often seen is nasal congestion or just normal obligate nose breathing that's a little bit noisy, because, and that's why I put this first one up, that's why it's a problem, right? Like as a newborn, as a baby, your job is to pee, poop, feed, and sleep. So if one out of those four things, which is feeding, and when you feed, you have your mouth, like, it's not like we eat and swallow and take a breath. You have your whole mouth plugged up, and you only breathe through your nose, and they are obligate nose breathers to begin with, that meaning that they pretty much only breathe through their noses. It makes it a problem. So that's why, you know, so many people come in and they're like, it's a lot of noise. If it is just snot or congestion, like as far as a little bit of edema or even just dried normal boogers, because we all have boogers, you can get them out using some saline. These are two different types of salines you can buy, in the sense that they're the same saline, it's just different delivery things. I like to share the bottom one, because as the kids get older, this one actually, it's like an aerosol spray, and so that if you like have one shot, sometimes it's good to use the one that is the other one, so that's the blue ball.
Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
We're most familiar with, but it's really,
Nou ja, ik ben wel blij dat ik gewoon nog leef natuurlijk. Hoewel ik niet. Ik heb nog.
difficult to use. These are two other ones that are basically like the nose freeda. But there are these other ones, because there are things that are other brands and
Le spalle, dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre. Non è...
There he is.
Hurry.
So what they do though, you see the mom's mouth is on one end of the tube, then they have a filter and they have a trap. And then they have the thing that goes into the baby's nose. And so if you put in a little saline drops or give them a warm bath before to kind of loosen up all the mucus, then you can suck the snot out without the snot going into the mom's mouth or the parent's mouth, caregiver's mouth. And it will make the baby a lot happier. So.
Yeah.
Good. Okay. Any comments, any suggestions, any practical tips about snot sucking? We've all talked to parents about it, right? any challenges?
Sneezing, the nasal congestion, the periodic breathing, right? So periodic breathing they can't pause for 25 seconds. The whole breathing delay, so if you're assessing for history, I think it's very important to understand how much experience the mom have, just because that's going to affect their mental health. I think another thing that's really important is that pediatric parents are often concerned when the kids come right, and the chief concern is often, oh, the baby's coughing. So I always, even if we're sending them home, I always like to encourage parents to show them how to be able to do that, how to adult stuff, especially sleeping today, and encourage them not to ever give it cough suppressive medication. Those things have toxic side effects, and the cough mechanism is actually
Yeah, these are all, and it's good to, even if they didn't come in for the chief complaint of like, my nose is stuffed, like their nose is going to be stuffed and it's going to be really annoying and they're going to be losing sleep over it. So you might as well take that moment and teach them about it. So, so laryngomalacia, again, most of the times laryngomalacia is going to be pretty benign in that it's something that babies grow out of. And so again, this is something early on, and it's because their larynx is, sort of soft and floppy. And so when they're supine, they make the noise. The way to diagnose is when they're supine, they make the noise. When you sit them up, they stop making the noise. So they're down in their backs, they go, and then you sit them up and they're fine. There are some kids though that end up trached for this. So you do have to, it runs the whole spectrum. And just to understand, I like that picture on the side, and that it shows you what normal is and then what is not normal. And then they actually can do surgery to do a plasty of the larynx and kind of help fix it. And then part of that, so the trach too, these are the kids that it really scares me to see trach, because they're totally normal kids, right? And trachs are horrible, like little babies and toddlers especially when they come out. But they're waiting for everything to firm up, because as we talked about before, babies are squishy and floppy, and that's why all this happens, and that's why it happens young. And as they firm up, they set, so to speak, it will naturally get better for most, and may or may not need other interventions. Comments, questions? The next one that was on that list is coinal atresia, just to make sure you understand what this is. So bilateral coinal atresia should not be presenting unless they were born at home to the ED and how would that present? So we talked about sort of the way babies breathe. Let's say you did have bilateral or even unilateral and now with a cold. How would this baby present? It's not that tricky. It's just sort of like, if you just think about it. Go ahead. Yeah. Or then when their mouth is closed, they go blue. They can't breathe because they have this bony thing back there. There's no path to their obligate nose breathing. It's obligately plugged. So in the nursery, people will, check for coinal atresia by passing a feeding tube, and that's how you would diagnose it, in the ED as well. And when to suspect some of this, like something like this, is like, I always think of these kids when, for whatever it is, you have sort of that bell curve, and then, the majority of people are all within here, and when you start falling off on the ends, you're like, wow, you are really stuffy, like you are really bothered by this. Like that's when you need to start thinking, oh, maybe it's something else. Even if you have no idea what it is, that you need to start being like, maybe I need to get more, more heads on board with this. Another thing that does happen in newborns more, it can happen certainly in any age, but vocal cord paralysis, but that you might not think of otherwise. And so it doesn't have to be bilateral, it could be unilateral. And then it can be from sort of brain issues. It can be from recurrent laryngeal nerve trauma, post surgery. That would be like cardiac surgery, a little bit older. It can be from just sort of intubation trauma. But the thing that you're kind of looking for with this is that the baby is a bit hoarse when they cry. It isn't as forceful. And this is when this may be something that goes home to grandma, and grandma's like, that baby's not right. That baby's not loud enough. And they may come to you that way. So it depends. They can have recurrent aspiration, but it's, something to kind of look out for. Again, if they're kind of like, they're breathing, they're having some stridor, and they're not sounding right. Questions or comments on any of the little baby stuff? Moving along. So talking about infants, I chose a 5-month-old. And so what are some of the things that you would think of for an infant? You see chief complaint, noisy breathing, 5-month-old. URI, yes. So not really foreign body. And why not foreign body? Somebody else. So this is why I do break it down into the ages, because you can't form a 5-month, and I said a 5-month-old as opposed to a 9-month-old who now has a pincer grasp. So a 5-month-old is not, and this is an important thing to bring up. So thank you for bringing it up. Don't feel silly bringing it up. Is unless somebody put that foreign body into that child, that it shouldn't really be a foreign body because they don't have a pincer grasp. So there's that awful cold rattle, right? Not only is that sort of stuffy nose thing, but that rattle, every mom will be like, but you can feel it. You can feel it on their chest. And you can. It's like snot rattling in the back of their throat, and you can feel it, and it gets everybody very upset. Then there are all sorts of masses. We'll go into a little deeper. There's compression. And so these are things that you grow into. And this is why I'm saying a 5-month-old as opposed to a 4-day-old. And then there's the wheezing and grunting. So why should a baby that looks like this worry you? What do you suspect? What do you see this when they come in a little bit, they come in a little croupy? Yeah, just a little croupy, or what is this? These are the redness, right? It's the hemangiomas. And what do we call it? We call this actually the beard distribution. And the reason that this is potentially problematic is this is the same way. So if you think about this, I'm always like, how else can you think of it? Anchor it to something else you know about already. Sturge-Weber, right? When you have that hemangioma on your face, that you are worried about everything underneath it. You're worried that they're going to have glaucoma, that they're going to have an intracranial hemangioma and stuff like that. Same thing here. So these guys, especially when they have something in that distribution, you're worried that they have a hemangioma in their airway. And so the natural course of hemangiomas is that they grow, again, so on day 1, they're not going to have much of one, but they will grow until about a year, and then they will kind of get smaller until most of them are gone by 10 years old, like 50% at 5 and stuff like that. But meanwhile, in that first year, they're growing like crazy. And that's kind of bad if it's actually in your airway as a polyp, or, they start out like even just a little bit of redness there, like they have to be followed and they have to be taken care of. What do we think that is on the top? Louder. Yeah. And where does that come from? Mom, right? Again, so not really there for day 1, but they acquire HPV passing out. And then now it's gotten a little bit of time to grow. And so they can have laryngeal warts. And now they have a cold, or maybe it's just been growing because it's gotten some time to grow. So again, you have this kid that's like noisy, that they have a cold, but man, they are really noisy. Like this is noisier than you're comfortable with, or you're just like, it's just too croupy, too many times with croup or something like that. and you have to start thinking, what else could be underlying this? And obviously, if it grows big enough, it can occlude your airway, and that's no good. Another thing, again, when we talk about kids that are a bit croupy and having some more distress than you would kind of expect, would be subglottic stenosis. And what's the history that you want to get with this one? Were they intubated when they were little? They're 5 months now, but you know, when they were newborns, because the babies have, you know, that natural airway narrowing, which is why we don't use cuff tubes in the neonates, and we did not use cuff tubes in kids for a long time. And you should probably think about it in a neonate, probably not using a cuff tube too if it's just coming in as a neonate, because what happens is you get the edema, or you get pressure, and then you get injury to the airway, and then subsequently they can get granulation tissue in there and get significant stenosis. And some kids, when they get really bad stenosis from this, will get trached. So it can be bad, so be aware. Another thing that you should think about, far more rare, but I feel like in peds we hear about it and talk about it a lot. But I think it's very important just to at least know what it is, so that you can at least have it on your radar so you can look for it, or is a vascular ring or sling. And a sling is, you know, the part way, and the ring is the whole thing. And so these are congenital malformations of the great arteries, areas, rings, that not by compressing or not by being intrinsic to the airway, but it's because of the external compression. And again, this is something that as people grow, these things kind of can potentially manifest because they're just, you're growing, and different things grow at different rates. But to something to think about if you're having somebody that's having either sort of biphasic stridor, their wheezing stridor doesn't quite match what you're supposed to be hearing. They've had so many incidences of, pneumonia or wheezing that doesn't quite respond to the bronchodilators, but you're like, this is your 7th episode of RSV? Like, what is going on here? That would be somebody that you might want to consider. And for the most part, you should be able to see at least some difference in the shadow, like a peds radiologist, if not, depending on how subtle they are, but you should be able to see something on the x-ray. So that would be the type of thing. And, or if you're admitting that, just at least raise it, right? You want to make sure that that it gets brought up sooner than later. Not going to say much about wheezing. We talked a lot about bronchiolitis this morning. But the reason I bring this up is that you also have to remember that with that noisy breathing, as a 5-month-old, you can also have CHF. What is the usual reason for this to happen? Usual may not be the right word. Why does this happen at 5 months? There's a couple different reasons. Yeah. Anyone? And if you see enough kids, you will have one of these kids like sneak into you in bronchiolitis season, huffing and puffing, looking like the rest of them. So it's one of those things that you need to keep on your radar. So you can have, because of SVT, right, that they've had, and they may not be in SVT right now, or, but again, if they're fatiguing from that. But the other part about, and this age is that like a large VSD. And that may have gone missed because this is when the pressures have dropped and now you're getting left to right shunting. And when they're big enough, again, when we talk about wheezing and noises, and I remember I was taught about how, what a murmur is. A murmur is the flow. It's kind of like a hose. You have a lot of water going through a hose and there's no noise because nothing's occluding it. Once you put your finger on it, you kink it, you start getting noise. And so that's the same thing that happens. And that's how a very large VSD can go through and not present until it's presenting with failure. So always just keep this in the back of your mind. This kid, this age, when you're wheezing, listen for gallops, listen for a murmur, feel their liver. So Let me see. I'm gonna give up soon if I. So what are those yellow things? Peeps, right? So. So that's probably the most important noise that I wanted to share, is just because, and especially when they're crying, sometimes you cannot pay attention to it as pathologic, but when they are.
Every vacation at a verbal home meets someone like you.
But that's a really not good sound to hear. So that's the sound that, especially when you hear any, but this one, when you hear it from across the room, you got to get up and you got to see who's grunting, because that's a child that is peeping. They're trying to auto peep because they're trying to not have their airways collapse. And so you gotta pay attention to that one sooner than later. Okay, so toddler, I gotta kind of move, I think. So what is special about toddlers? Oh, shoot. Okay, so we're getting bigger, we're moving, we're changing. One of the things that, you know, in one of those pictures we started up higher. And snoring, it sounds very benign, but it's not always that benign. Then there's the croup. 5 months old is a little bit young for croup, which is why I put 5-month-old down there. And so that is why also, if you heard croup in a 5-month-old, you should think about those other things. You know what I mean? Like, you should say that's too young, and maybe they have a polyp, maybe they have Hemangiomas, maybe they have something. You can have just regular old plain croup at 2 years old. Foreign body, 2-year-olds are great at putting things in their mouths, and they are not good about telling you about them either. And then we already went over compression, wheezing, grunting. So I want to take a few minutes to talk about snoring and OSA, because if you don't know to look for this, you don't know to ask about this, you and the parent are going to go like this. Because this, when you have that awake child, they're not snoring, right? And they can't necessarily, the way that croup too, sometimes they can't describe to you what that noise was that scared them so much that they needed to come to you. They will have watched their child be apneic and struggling. And some of them nowadays, it's good that they'll bring in their phones and they'll show you the video and you're like, got it. I'll never forget, a couple of years ago, the asthma room was packed, and like there was a mother, it was like, oh, she's got a cold, whatever, you know, it was really busy. And then, so she was sitting there waiting for me to go see her. And then like all of a sudden there was like this whole hullabaloo back there, because everyone all the parents in the asthma room were watching this kid who had fallen asleep now and is going, you know, they're watching this kid really struggle to breathe, and everyone's like, something is really wrong with this kid. But, you know, the mother was not able to elaborate that when it's hard to explain it, what's going on, but something really scared them. So you have to you can do that. That's usually what I will do with them. I will be like, is this what happened? And they fall asleep, and then they start breathing, and they go, and they'll be like, yeah, that's it. And so breathing is good, right? Not breathing is bad. And so it is something we have to worry about, because when it is extreme, most of these kids will have had this underlying mild, like they'll have had adenoid hypertrophy. And this is sort of the adenoid facies, which is an allergic facies, and they're chronic mouth breathers. They tend to be skinny. And that's why you get so many kids getting TNAs at like 18 months to like 2.5, is because they naturally, the lymphoid tissue hypertrophies, and then it kind of regresses. So that's why, again, this age is prime for this, and they get lots of colds, right? So the two of them on top of each other. But if it's bad, if they're really scared, then it's not just snoring, right? And it's not just a little something that's going to go away. And you might want to let them sleep for a little bit and watch them and put them on a pulse ox and see how much they desat to. If they're down to like 85 or lower, like maybe they need to be admitted. Maybe they need some CPAP. Or maybe they need some steroids to shrink down their lymphoid tissue. And even this in the older kids have had them too, that they, you know, they really, I mean, you've seen the adults, their breathing is good. A and B are good. So, but this is something that you need to kind of be aware of. Does anyone have any comments about this? I feel like this is something people don't talk about, but practically is really important. Yeah.
So for adults with OSA, like what happens, sometimes you just get away with positional changes. Just like on your side and prior to have the same thing, like the same advice. Parents work, like
If they're, yeah, I do on the ones that are not so bad, like trying to get them to sleep on their belly or, you know, sitting up and stuff like that. And then like you can certainly try some steroids if we use steroids for everything else, right? That can be, but if they're horrible, you know, it's very, very few that have admitted for positive pressure, like, but there are. And some, you know, people, the same way that with the adults, there will be kids that are on this at home or they need their adenoids out. Yes.
I like to think about, is the snoring consent? So when the kid goes to sleep, they start snoring immediately, and if they are snoring, does it continue the whole night, or does it pause? Are there gaps? Like as a snorer, you may pause and gap throughout the night, but the question is, are you having apnea during one of those pauses or gapping? So what I do when I was in primary practice as a resident, I would say to the parent, hey, are you noticing the snoring happening all night long? And if they said yes, I'd say, oh, well, that might be the enlarged adenoids, it might be this nasal congestion, it might be something that you can follow up later. But if it's something that has frequent pauses, then I say to them, hey, you should probably go see a pulmonologist sooner rather than later, because the pauses, while they may be physiologic, may be apneic episodes. So that's more of a sign you have to dig in further again with the specialist.
And actually, I'm glad you reminded me. I will also tell them to videotape it and just bring it to their doctor, because it's just so much easier to explain what the issue is. Jimmy?
That was gonna be my question, maybe I'll answer this. I think for adults, we usually send them to sleep specialist, pulmonary, that's the same.
Yeah, it is.
Typically, ENT issue rather than
The sleep studies are done by
Pulmonary are doing them. Yeah.
So the pulmonologist will evaluate for sleep studies, and they'll get you the AHI number and all the numbers you're used to seeing on a sleep study report. And then if they need surgical correction, then they'll send it to you.
So the ADP actually published OSA guidelines in 2012 with its key action statements, and I think it says like clinicians should ask about snoring, but they have a table too that specifically talks about symptoms and signs, and if they have these symptoms, then it just says refer to your nose and throat. They should get a sleep polysomnography, but it says frequent snoring more than 3 nights a week, labored breathing during sleep, gas/snoring noises, if they're having sleep enuresis, so they're peeing themselves at nighttime, sleeping in a seated position with the neck hyperextended, headaches on awakening, daytime sleepiness, and then it talks about some physical examination findings. So just letting you know that's something that you can look up, and then you can look up the key action statements to help you guide your next steps.
Yeah, OSA is actually a bigger topic, like wasn't planned, but at the same time, you should, it's important because it can also be a confounder to like she said, enuresis, but then ADHD, right? Like this diagnosis of ADHD, if the kids are not sleeping because they're not breathing, you know, if we look at how many kids end up on meds and stuff like that, this is actually one of the first things you're supposed to screen for. So it's a whole nother thing, but it is actually it's pretty important. And I do find that a lot of it's one of those things that doesn't sound very, I don't know if important is it that our families don't get screened well for. Is that PC enough? Okay, I'm gonna kind of go fast, but David said I had a little extra time. So croup, you mentioned croup, just again, you can talk about croup a whole lot more, but just to focus on what are the noises and why do you get the noises. You're getting edema by the larynx. I always tell the parents, it's like when you get laryngitis, right? It's your itis of your larynx. Since your airway is bigger, it doesn't actually cause you problems. And so when you get this edema of the smaller airway, you get the noise of the croup. Foreign bodies, just to remember, foreign bodies can cause wheezing and they can cause stridor. Because this one that went down, you know, the screw that's down in the bottom in the bronchus is going to be a potential wheezing issue with more unilateral wheezing and or infection. Whereas the one on the top, is that airway or is that esophageal? How do you know?
It's,
Why?
Because it's flat, as opposed to being vertical, if it was stuck within the port, it would gloss, it would be vertical. Or like that.
Yeah. So whenever that's theoretically how you think of, you know, because your vocal cords are like this and it goes down that way. It also has to do with, I think, just the shape of the two tubes. The places that you do get stuck are those different places, so that your cricopharyngeus, you're going to get your stridor. Again, we said upper. You should get stridor if with the compression. We're talking about compression on the airway from a large mass is basically what we're talking about. And then the aortic knob, you may have biphasic, or you could potentially have wheezing. And then the bottom one, you're not really worried about. I mean, you're worried about as a foreign body, but not with breathing. Yes.
Don't picture that the esophagus is in the back and it rests against the vertebral bodies. And therefore, it's pushed flat against the body. That's how the coinal lies. The trachea has the rings and the C is open in the back. So if the coin is large enough to stick out, it's going to poke out between the back of the ring. That's why it's going to logically differ.
Nice. Okay, so moving along, we're gonna like just breeze by school age, because now school age, they can talk to you. They've had some history, sort of the common things are there, but we're gonna skip them. Sorry, school age children. Because I want to move on to the adolescents, and I do want to spend a little extra time on vocal cord dysfunction and conversion disorder, because this is something, again, we're talking about like recognition with this whole talk, but I find that is probably pretty much under-recognized. How many people have had patients with vocal cord dysfunction? A fair amount, okay. Because I find, because you will find people that have been like intubated and for their asthma, and then it does definitely coexist with asthma, but then you find out, you know, down the line that they've been intubated probably for their vocal cord dysfunction, which they probably didn't need to be. Other names for this are paradoxical vocal cord motion, Munchausen stridor, factitious asthma, functional laryngeal stridor. All these are sort of the same thing. As far as symptoms, this is why it can mimic asthma or be mistaken as asthma, because you have similar symptoms. But more often you will also have this stridor noise, which sometimes when people, have you found that these people are somewhat stridulous, but it sounds like wheezy almost. And so the way to distinguish that is like sort of listening up at the neck versus listening down at the bases, and trying to figure out, you know, is this transmitted airway sounds from up here and down in the bottom, or is it truly down in the bottom noises? You also, if you ask them when they say, I feel tight. So if you get more specific, you say, where do you feel tight? And they will often point to their neck. And you're like, oh, well, because when we think of tight, we usually think of down below. And then some of them will be like, it's choking me. The other reason why this is really tricky as far as distinguishing it from asthma, which again, it can coexist with asthma and often does, is it has the same triggers. Like, that's so not helpful, right? Exercise, anxiety, or depression, which I never know, you know, like it could be, because again, it can be Munchausen's or factitious, and it seems like in conversion disorders somewhere within there, are they anxious because they can't breathe, or are they can't breathe because they're anxious? And depression and sort of psych diagnoses also tend to go along with all of this. But we also know that strong emotion can trigger asthma. So it's all bundled in there. You have to just be a little careful how you tease these out, but it may be a clue that this is what's going on. The other part of it is irritants. So any irritants from perfumes, exhaust, the postnasal drip from sinusitis or GERD, reflux, any of that stuff will irritate your vocal cords and can trigger things as well. So, and it triggers asthma. So as far as how to diagnose it, it's really tricky to diagnose because obviously if it's not dysfunctioning at the time, they're normal. So when they kind of have to be triggered to and have their evaluation when they are having something going on. I was looking at, I'm looking at pictures and stuff. I was like looking at these PFT graphs and I was like, wait, nobody cares about what a PFT graph's. But direct laryngoscopy might be more interesting. And so I will call, ENT to come look at these kids that I think have this, but it's not necessarily 100% diagnostic because again, if they're not dysfunctioning at the moment, then they're going to have a normal exam. And so what we're normally you have mild opening and inspiration of your vocal cords and then mild closing in expiration. And so you can see that with the top one, the inhalation, it's supposed to be open and it's actually closed. So a little bit about management with this. Acutely, you're going to be thinking about trying to relieve them. They talk about a sniff, purse lift out. So going like, sort of, it's almost like, I think of it as almost like that positive pressure when you think about vocal cord spasm. Like if you give somebody ketamine and they have laryngospasm, you're supposed to use strong, sort of like solid, positive pressure to break the spasm. And that's sort of the idea of probably the purse slips out. And the other people that are going to be able to teach them the different techniques, especially if this is a recurrent problem, is speech therapy. So just to make sure you can refer them to somebody. It's a very frustrating thing because they're very bothered by it. You're kind of, everyone else is not necessarily physically that bothered by it as far as us as physicians, because you're like, well, no, you can breathe, but they're really feeling unwell. So you can refer them to speech therapy and they can teach them how to manage these things. Acutely, if they do fall into that little bit that get themselves really sick because if their vocal cords are really closed, you can try Heliox, again, to make the flow of the air more lamellar. And then the other thing you can do is try and treat their underlying causes. If they have sinusitis, then treat their sinusitis. If they have, other postnasal drip or something like that, or GERD, try and treat that. Does anyone have comments on this? Because this I find to be totally fascinating, because especially the adolescents, they come in with this, they're very frustrated with it. I feel like we don't do a great job with this as far as figuring out how to make them feel better about it. No? Okay. So anyway, that's really all I have. Just to kind of recap, talking about the different causes of noises from top to bottom. This is sort of a differentials type of talk, trying to keep everything in mind that different ages are going to have, and different sounds are going to have different things to think about. But there is a lot to think about. And some of them are benign and some of them are not so benign. And that's not makes everything worse. So. Questions, comments? Yes.
So a lot of the causes usually structural things. So if you have immunity that comes in, they don't seem to get kind of infectious sores. So these kids that will get used to still.
So it's depending on, I would actually be a little more aggressive with them because their airways are so small to start with. And if you have anything that obstructs them significantly, I'm trying to think what I have done. I mean, it depends how bad it is, but I would have a low threshold to, especially here where we do have ENT readily available. I think it's a good idea because if they have significant delay, and again, if things grow in the interim to before they get seen.
Most of these congenital abnormalities can be caught in the nursery. If you think about it, they'll start having the congenital abnormality, they'll start having. So in terms of like most of the reasons we see neonates or even with breathing issues, usually it's something in the upper airway, aka like snot, or you have your edema of your upper airway here in the setting of preeclampsia, or you have like a lower respiratory issue, aka bronchitis or asthma. So it's definitely something to keep on your other things that theoretically should have been present. But vascular slings is like a classic thing of it's subacute enough that it might present to you later on, then it's just like this is a thing that's been going on for a really long time, or it required respiratory support intermittently throughout their life, especially when they're sick. You just don't have a good reason why it happens.
Anyone else?
I think the neonatal period is also really interesting on a lot of anatomical stuff. So things like that activate those target syndrome, so that's like one point that's abnormal. There's something else that might just exist. I think right now, especially during COVID, a lot of people haven't had
Yeah.
optimal prevention. So did they get any prevention care? Did they go to their screening? Do they have any idea if we has any medical conditions? We need to work at home. So there's all sorts of types of questions that those have. And then it's also interesting to think about outside of the respiratory system. Are there underlying things like therapy, metabolic condition that can cause these that could be presented in saying, oh, I think it's really fast, but it's actually an underlying respiratory or metabolic. Always keeping this such a great reading voices are so subtle in children. Always keeping a different law and outside everything.
I have one more great story that goes along with the missed things. A couple of years ago, we had this baby that turns out actually had a cleft. And it was the second time that I saw, how the kids will come back to you. It was a, far back cleft, obviously got out of the nursery, was not born at home. And it wasn't, and it came because of like reflux type of thing, like noise, milk out the nose type of complaint that you're like, okay, fine. And what was even funnier is I think the resident had discharged this kid from the nursery and saw it twice with me. But when the dad came back, I took one look at the dad and he had a scar. And I was like, oh shit, like, I know what's wrong. Like, why are you back a second time with milk through the nose? And I was like, oh, well, let me look in your mouth. Okay, now I know. It's because, yeah, they've got a cleft. So we do exactly, and especially with COVID, I think, we do need to look. I'm going to take 1 second to do a public service announcement because I promised the outpatient people over at county while I had the floor. If a patient if they need follow-up and they are not our clinic patient, if they are a UHB clinic patient, they are a private pediatrician clinic patient, do not send them to our clinic because it doesn't help anyone. They don't show up. If they do show up, it makes the pediatricians unhappy. The insurance doesn't cover it. Just don't do it. Ask who their actual doctor is and send them back to there. That's my 2 cents. Okay.